Hi, my name is Dr. Boraiah. I'm one of the orthopedic surgeons. I do hip and knee reconstruction and hip preservation. I'm an associate professor at Northwell. I'm the fellowship director for the adult joint reconstruction for the hip and knee program at the North Shore and LIJ Hospital of Northwell. Thank you for giving me this opportunity and just to go over some joint replacements ins and out, the advances, including anterior hip replacement and the robotics in joint replacement. So what is new? What can you expect? What is arthritis? And what are the treatments we have for this problem? I just want to pay some respect to one of my colleagues, Dr. Oskina is not with us anymore. He was my partner. He was one of my senior partners, so he's not with us. So what are we going to talk about today? So what exactly is arthritis? And what is hip arthritis? And what is knee arthritis? What are the symptoms of arthritis? What are the treatment options? The surgical treatment options, including hip and knee replacement. And what about anterior hip replacement? And then are you a candidate? And the robotics. These are the titles we're going to look under today to see what are the options we have for arthritis. So arthritis and joint replacement. I'm just going to start quickly before I get into the nuts and bolts to just address this common perception. People always say, hey, am I too young to get in a hip replacement or knee replacement? Or am I too old to get a knee replacement or hip replacement? Well, the answer is not straightforward, but certainly the joint replacement is not an operation for the elderly. It's not performed only for the elderly people. It is performed for people who have arthritis and whose lifestyle is changed because they have arthritis. So now let's just go to this slide. This is one of my patients. He's in his early mid-30s, and he's an MMA artist. His life had changed because he couldn't do well now, because he couldn't do any of the activities. Now, as we can see, this is a few months after the hip replacement. He's doing all this, and he started his own studio. He's a teacher now, and he's an agent. He's doing extremely well in his life. So long story short, he's a 30-year-old who had a joint replacement who is back to what he was doing, and he's also excelled, and his life is back. He's on track. He's financially happy, his career is successful. So that's an example. I'm just going to show you another example. This is another patient of mine who was a circus delight dancer, and she could not perform what she wanted to do. And this video is 8 months post-operatively after a hip replacement. And it is very uncommon to do all these extreme motions after hip replacement. But when we tailor-make the operation, individualize the operation for the patient-specific demands, most patients will get to their pre-injury level. Now, I'm not saying that you should go and do this kind of activities, performance, martial art, or this kind of dancing if you haven't done it before. That's going to lead to trouble. I would not recommend that. But if you're performing these kind of stuff pre-surgery, and that's your lifestyle, and you're missing out on that lifestyle, joint replacements do give your life back most of the time. So I do tailor-make and individualize the surgery treatment options for that patient's physical demands. So this is just to set an idea that it is not an operation for the elderly. It is performed for the right reasons, when you exhausted your conservative treatment, it definitely does give your life back. So now let's see. So what exactly is arthritis? Arthritis, and where can it happen? Arthritis just basically means your joints, or the cartilage, is wearing out. Just the way the common example I tell the patients is, imagine the tire of the car is wearing out. People always say, oh, I got a shot. Am I better? Is it looking better? It usually does not work like that. Once the cartilage starts to wear, it does not come back. So the tire, once worn out, it's not coming back. The tire worn is worn out unless you change the tire. Kind of similar analogy, not exactly, but just to get an idea. It can happen in any part of the body, including all joints. Anything that moves, has cartilage, can develop arthritis. So on the left here, you can see a normal knee. On the right here, you can see a little bit of an arthritic knee. So what does arthritis mean? It means the cartilage that is between the two bones inside your joint is damaged. Now, that can happen from any reason. It could be just wear from normal wear and tear. It could be wear because of you've used too much. You are genetically predisposed and you wore out, like you say, you play football all your life. You overuse in predisposed individuals can lead to wear and tear. It can happen because of its cartilage destruction. It can happen because of osteoarthritis. This is the most common one. It's a wear and tear, age-related and genetic predisposed individual. This is most common form of arthritis. And we have other forms of arthritis, which I didn't mention, is traumatic arthritis. When people have a fracture that goes through the joint, few years down the line, they can have arthritis. You can have arthritis from rheumatoid arthritis. There's a bunch of reasons why arthritis can develop. The end result is the cartilage is damaged and the joint is destroyed. So what are the treatment options for this? So in my practice, we extensively try physical therapy. I'm a firm believer of physical therapy. Physical therapy is conditioning for athletes, for anybody. Conditioning is really essential. People say, oh, I did physical therapy 2 years ago. Why do I have to do it now? Physical therapy is like working out. If you're working out, you're in shape. If you're not in shape. So physical therapy is really essential. It gets your muscles strong. Improves your conditioning and gets you stretched and strong. I think physical therapy is really one of the main modalities of treatment in my practice. And I do emphasize on the patients that do it for a long time. And supportive braces. So these braces don't change the course of the problem, but they do give you support. So if you have bad arthritis, if your knee is a little bit bent, so these braces do give you some structural support. They don't change the course of the arthritis, but it makes the patient feel a little bit more secure. There's a small role for these supportive devices like knee brace in the road treatment of arthritis, not a lot. It depends again on the patient. What are they expecting, where they are. And now there are supplements. People always ask, can I take turmeric? Can I take glucosamine? So now these are all things, there is no real evidence to support that this helps. There's no real evidence to say it doesn't really help. There's some animal studies to say that turmeric is helpful, but in human data is very minimal. And so when the patients ask me, can I take it? I say, yeah, you can take it. It's really not monitored by the FDA, so it's kind of over the counter. But there's really, you can try it, but there's no proven evidence like everything else, like healthy living, keeping your weight light, doing your exercises is the best thing you can do to help yourself and your arthritis. So that's my advice to patients. So just keep light, be healthy, eat healthy, and these supplements will help you. I just don't know to what extent they help you. We don't have any studies to support these kind of supplements. So now weight. It's a hard topic to discuss for everybody, even me. We always have to, all of us, most of us could lose a few pounds, and including me. It's a hard topic to address, but I think it has to be addressed, and that's one of the most important things. So keeping weight light takes the load off the joint. It will not bring the cartilage back, but it will definitely help your life. It will help you get going and moving. So we have to address the weight. And these are the radiographs kind of showing. The one with the lines is the left hip, so we don't get confused. The one without the lines is actually the right hip. So see how nice and clean the joint space looks compared to the one on the left, which is the bone-on-bone arthritis. The joint is worn out. So patients who have this kind of X-ray, it's like an end-stage arthritis. So their motion is limited. They're very protected. They are kind of stiff. They have a little bit of flexed gait. All these things will have an effect on the way you walk, and it also affects your spine, it affects your back, it affects your range of motion. It's not just the pain. Sometimes people say, I don't have pain, but they're not moving that leg that much, and they slow down. And I think one of the big things I tell people who say, oh, I don't have any pain, yeah, I think it's fine, you don't have any pain, but how much are you actually doing? If you're sitting on the couch or just walking basic, you're really not using that. So once you put it to use, that's when it hurts. Sometimes people surprise me with bad end-stage arthritis who have no pain and who are functioning very well and who have very minimal pain. I tell them, I think there's no reason for any kind of surgical intervention because they're functioning and their lifestyle is pretty good. They're not compromised. They're working out. They're being healthy. For those people, it's definitely advisable to just continue their conservative treatment, therapy, strengthening, and occasional Advil or any form of anti-inflammatory medication. So unless your function is compromised and pain is an issue, there's no reason to consider surgery. So the pain and function, if they're compromised, you should consider treatment options, including surgical and conservative treatment options. So hip replacement. So I'm just going to talk quickly about hip and knees. I'm just going to start with the hip. Hip replacement is historically one of the most successful operations. Most of the people who do who I perform hip replacement are extremely happy. And it's almost compared to the success rate of an appendicitis. So people who have appendicitis, who go to the hospital, get their appendix removed, it's a successful operation unless something goes wrong. So it's kind of compared to that level of success, if not better. Most people are very happy, are done for the right reasons, and do the right rehab. So there's another treatment option for hip injections, which is an injection into the hip. I do a lot of hip replacements and hip arthroscopies for athletes, but hip injections should be done, in my opinion, under some form of imaging, either X-ray or ultrasound. So I typically don't perform them in my office, so I send them out to the radiologist or pain management doctor who has some form of imaging to do the injection. Knee injections, I do them in the office all the time. Hip injections, I try not to do them that much, or try not to do them at all into the joint because you need some form of imaging. So hip injections do give temporary relief. It's not the same as knee injections. Knee injections are used a little bit more widely, and the results are a little bit more predictable than the hip injection. Hip injection is more for diagnostic purposes to see where the pain is coming from. Or sometimes we use it just to get by, say my daughter's getting married, I need another few months, I can't do anything, I want to go dance. Yeah, you can try it, but if you can't keep injecting over and over. And this is the results of surgery. Like I said, this joint replacement people, the pains and the function level tremendously goes up. This is the Oxford Hip Score. As we can see, the results and satisfaction is very high with joint replacement. This is kind of what we use, the implants. There are 4 parts to it. There's a cup, there's a stem, there's a liner, and then there's a ball. They're all put together. There's a lot of modularity, meaning there's a lot of size options. So we fit the right size to fit the bone and to match the length of the legs. There's a lot of technicalities. We do all this preoperative planning. So it's a lot of things that go into planning and performing to achieve good results. And this is what I kind of said. This is kind of what it looks like. We can see there's pieces there, the 4 pieces with modularity. So it gives you options to see which best fits your bone, which best recreates your anatomy. So now, what are we going to do? So who is a candidate for a joint replacement, hip replacement, or knee replacement? Is it funny patient? Is it old patient, young patient? It's really not based on any of these criteria. It's really based on how bad is your arthritis, what is your pain level, and what is your functional status. If we can make any of these things better, I think joint replacement is an option for you. But having to understand, you have to understand, or the doctors and the surgeons and the patients have to understand that patients have tried everything that they can conservatively, and you have to set the expectations right. You can't tell the patient that you're going to be running a marathon in two months. It's not going to happen. Some people think like, they come to my office sometimes in 2 weeks and say, oh, it still hurts here, but that's muscle pain. Now, it's not like going to a car dealership and get a new car and it's working fine. It doesn't work like that. The body has to heal. It has to adapt to the new hip. So now if you're going to have a little bit of pain after 2 weeks after surgery, the muscle pain, that is normal. It's not like you fix the hip and you walk out with a new hip like you're walking out with a new car. It doesn't work like that, but we are heading there with multiple pain management protocols and various new technologies, but it's kind of unrealistic to expect that you're going to walk out pain-free on the day or 2 days after surgery. So when people say, oh, I have pain here, is that really hip pain? Not really. It's more of in the bursa. It's kind of more from the bursa and muscular pain. So hip pain typically comes in the groin. Now you can have pain all around the hip for various reasons. People who have advanced arthritis can develop muscle pain secondary to it. But if you have a pain that is kind of looking like that for the last month or so, very unlikely you have hip arthritis or hip issues. It's most likely muscular pain, bursitis, tendinitis. So those treatment options for them are definitely not surgical, but you have to get an x-ray to evaluate them, do physical therapy, and try other form of conservative treatment. This is like a special table I use in my practice. It's called HANA table. I mean, there's various companies make this, but this is kind of what I use. The reason I use the table, it's because my incisions are very small, about 6 to 7 centimeters, sometimes 8 centimeters. It gives me options to cut very little of the tissues because you can control the position of the leg and the patient positioning very precisely. So this is kind of what I use. So now people always ask, what is anterior approach? What is posterior approach? Anterior approach is just the way you go approach the hip. Now there are various ways. There's anterior approach, there's posterior, meaning from the front, from the back, from the side. I prefer doing all my hips from the front because it's just very less invasive. You don't cut the muscle, you just spread them. And most people recover fairly uneventfully once the tissues are all healed. Now, there are other approaches people do for various reasons. I only do posterior approach when its patient has a more complicated problem, it's a revision or something else we're doing. But for most primary, meaning the first time patients, regardless of the weight, most of the times I do, or all the times I do, from the front, which is anterior. So now the advantages of that, I mean, there's a big debate, but I think it's less of a debate now that people are doing more and more anterior, and patients prefer anterior. Surgeons, new surgeons coming fresh out of training prefer anterior. The parts you put in anterior, posterior is the same. Most of the times it can be same. It's just the way you do it. Anterior approach advantages, there's no muscle cutting. The rate of dislocation is lower. Now some people say the fracture rate can be high. A fracture can happen both from the front and from the anterior or posterior, meaning from the front and the back. It depends on the level of surgeon's experience in each of these approaches. And now I'm just going to talk about robotics. What is robotics? This is like an iRobot. When I tell people we're going to do robotics, they literally think that we have like the robot that looks like this from a Stop and Shop, or from the iRobot that's going to do surgery on you. That's not the case. I still do the surgery. The robot definitely does not look like that. So the robot is like an 800-pound machine that has an arm. So that's what the robot is. I mean, there's various companies that make the robot. This happens to be the one I use. It's called Mako. Every company has coming up with their own version, and some of them are good, some of them are not so good. But robotics is definitely is the current, and it has definitely more a future to it, just because it eliminates outliers. Now, what is the benefit of robotic surgery? Now, if you ask people, there are surgeons who say you don't need a robot to do this, but I'm not quite sure I agree with that statement, because it's just another tool. There is nothing wrong with having another tool to precisely do the operation. Now, can you do a knee replacement or hip replacement without the robot? Absolutely, yes. You can. The robot is another tool. It just makes it more precise, and I just prefer to do it this way. So the robotic technology in total joint replacement is not that new, fairly new, about 7, 8, 9 years. We used to do a lot of unicompartmental knees with the robot. The total knee platform came out about in 2015 or 2016, and there's a lot of surgeons who are adapting the robotics just because it's more precise, it eliminates the outliers. Now you can see in the last thing that the 6.8% of the surgeons were using then, now it's about 17%. This is in 2015. I don't really have the numbers for today, but it's is much, much higher. It gives you a little bit more predictable result. So what are the pros of robotic surgery? It optimizes the bone preparation. It controls your component alignment. It reduces alignment outliers. And you can calculate and manage soft tissue balance. Now, there is no substitute for a good surgeon. There is no substitute for good planning surgically. There's no substitute for a great patient, most importantly. But robot is just another tool that we can have just to make sure that, okay, this is what I'm going to cut the knee in this much degrees and this much degrees. But if you tell the robot, I'm going to cut it in this wrong angle, it will cut it. So now, if you give wrong information, it will give you wrong results. So again, the surgeon is still needed to tell the robot to do it this way. The robot is not going to do it on its own. We don't have artificial intelligence to say, okay, it's going to do it itself. No, your surgeon still has to do it. Surgeon tells the robot what to do, and the robot will execute the plan. It's like a football coach and the team. The coach still has to make the plan, but the players still have to execute. So it's a combination of both, the coach and the players, the surgeon and the robot. It's the same thing. The surgeon puts it in, and the robot just helps you. And the goals, like I said, it's a little bit more precise, increases efficiency. Cost is a little higher. Robot is an expensive machine as of now. The hospitals do take the brunt of paying for the robot. Northwell is the leader in adapting technologies. Northwell has been very helpful in addressing these kind of technology issues when it's needed. So yeah, it is expensive, but I think it makes up in the quality. So consistency, it streamlines the process, it's durable, and improved clinical results. So precision, like I said, these are basically some old studies in the last 5 years. It shows that the alignment of the tibia and the femur is much, much more accurate, fewer outliers, meaning if you do 100 patients and if you draw a bell graph, with a robotic surgery, most of the people are in the middle. And the outliers, meaning like 5% to the left, 5% to the right, it's a less occurrence of that with the robotic surgery. And again, this is another study which shows that there's no outliers in the robotic group. Like to that point, if you look at my patients' knees x-rays post-operatively, if you look 20 of them or 100 of them, they all kind of look the same. So it's good for me. I can sleep better at night knowing that how it's going to look. But now that does not always translate into patient outcome, right? Good x-rays does not always say, oh my God, the patient's doing great. There's a lot of things that go into it. This is just one of them, and then that one of them is just a little bit more predictable and reliable. Like I said, the cost is the big deal. There's some concerns of pin site exposure, so I'm not going to go into this, a little bit more technical, but those things are all kind of very minimal issues. You do have to get a CAT scan. You have to get some CAT scan for the preoperative planning. There's considered some radiation exposure, but they have very, very low dose CAT scan now. It's very low, and every year they're bringing the radiation exposure down for the planning CT. That's really less of a concern now. And again, the system costs. Somebody has to pay for the CT. Somebody has to pay for the machine. So these things are all concerns, but a lot of insurances are now realizing that since it reduces the outliers, it may be better for them, so that there's no reason to redo the surgery. So in a way, people are adapting it more frequently. And then learning curve, right? There's like, you have the greatest new tool, but somebody still has to do it. So there's a learning curve for the surgeon. You got to find out if your surgeon routinely does this. How many of them do they do? Is he comfortable with what he's doing? You don't want to somebody trying to experiment on you. So learning curve, whoever does your surgery, make sure they're comfortable with whatever they're doing. Now, it doesn't have to be robotic. It can be a good surgeon who does the way they do it and have their great results. It's great. So that's what we need. A good, honest surgeon who says, okay, you really need this operation, number one, and number two, this is the way I'm going to do it, and we have happy patients. That's really what you need. An honest surgeon and an honest opinion in whichever way he does it. And if it works, it will definitely work. And like I said, this is a radiation exposure. This is not really that much of an issue these days. This is kind of picture in the operating room. There's a lot of people there. The robot is the machine in the back. It's me and my PA and my surgical team. I have residents and fellows. So we plan all the implant positioning on the computer with the 3D models that the robot gives us. And then we match that to the patient's anatomy and do soft tissue balancing, and then the robot helps us do this. This is just a little slide to show how it looks like when we're doing surgery. So since all the planning is done on the computer, this is kind of what it looks like. The knee replacement is basically a resurfacing of the bone. It's not like we take your whole knee off. We just take a few millimeters of the bone and reshape it and resurface it. Most of the ligaments stay, and it's just basically a resurfacing. And this is kind of what it looks like. And during the surgery and exposure, to me, it gives a little bit more peace of mind knowing that all of my x-rays are going to look the same. It introduces more consistency in my surgical workflow, and these are the kind of the steps. So these are gaps. There's a little bit of change in philosophy of how you think to do the surgery because it's newer. There's a learning curve. You have to understand the system. You have to rethink. You have to think differently. But ultimately, end of the day, we're trying to help the patient and give a good result. So this is kind of how you balance the knee. If the knee is a little bent, to try and make them straight. These things are all done kind of before surgery, during surgery, to balance out what is the best for the patient. Again, it's all individualized. It's not one size fits all. So you have to do the planning and balancing. This all done. We are not in a point where we put all the information in the computer spits it out, and we do that. We are not there. Maybe someday we'll get there, but right now we're not there. The surgeon still has to do all the planning and do the surgery. So this is kind of what the saw looks like when we're doing virtually. This is what it kind of looks like. The robotic arm it's a heavy 800-pound robotic arm that will not let you cut in a different plane than what is planned. It's called the haptic boundaries. So these are some case examples. 47-year-old left knee, severe left knee. He's bad arthritis. We planned on the computer, balanced him. That's kind of what it looks like. The patient is doing great. This is another example, a 73-year-old patient with bad knees. We did this on the computer. So, end of the day, what I would like to say is surgical treatment option is reserved for people at the end stage of arthritis. So before surgery is considered, you have to make sure that you've exhausted all options, including physical therapy, injections, and surgery is not for everybody because there's a lot of things that go into it. So the way I look at it in my practice, I say, can I make this result better? Can I help this patient from surgery? That's how I look at it. But I have to exhaust all my other treatments, physical therapy, injections, and sometimes activity modification, doing things that a little differently will alleviate the symptoms. So all these things are considered, and then you consider surgery, and if they have to, and I tell most people that they can return to the arthritis level, and for most patients, they do well. So my recommendation or my advice or suggestion to the viewers is, if you have pain for a month or so, it's very unlikely to be arthritis. Exhaust, see a doctor, a medical doctor, or orthopedic surgeon, whoever you're comfortable with, and really get to the bottom of this. There's no harm in getting a second opinion because two pairs of eyes is always better. And and we always here to make the patients happy and help the patients. Thank you.